I've grown up spending hours in the phono lab with the lights out and the soundproof tiles, trying to understand these heart sounds, and then suddenly having echo come along and sort of make it much easier. I was really happy for an opportunity to resurrect something that I thought was extremely valuable and was killed for a number of reasons. And echo really did eliminate phonocardiography, and it also made teaching less emphasized. It seems that that's become a very abbreviated effort indeed. And I know that some clinicians are more thorough now that they know the exact diagnosis from echo, but others have become extremely cursory, and no one seems to notice that that's happened. So you see on the typical admission history and physical, S1, S2, no murmurs, gallops, and that's the end of the exam. Nobody comments on anything any further. So the opportunity to bring this all back was really an exciting one. And so I've been using this device now intensely for a year. I don't use anything else in auscultation. And having on-demand, real-time phono as you listen has been really extremely interesting, and I think has improved my own skills and teaching. I don't know. I hope I don't get any negative comments about that latter point. Okay, the device you've seen from AT's talk, and just digitized heart sound, real time, and then all the research questions that have come up. This was a patient in clinic last week who graciously offered me his chest for your pleasure. And you can see we have the device placed. You can get an idea of how big it is. You can see it in the back of the room as well. And it's very easy to use there. So I'm going to give you my clinical impressions, and going to have some of our former fellows who did beautiful research projects, and then talk about what I'd like to see in the future as far as research goes. Okay, now this is what I'm going to try to cover: the first heart sound, some comments about murmurs and how that's helped me in the clinic, a little bit about second heart sounds, blood pressure, and the pulmonary exam. And this latter turns out to be very important. I don't think Arvind covered that at all, and yet that's something that's really been helpful in my own practice. As you know, nurses now slap on a blood pressure cuff over the shirt, and they push the automated button, and that's the blood pressure everybody deals with. It's accepted as gospel, and I have a new approach using electronic, using the HD stethoscope, which I think has greatly improved that, and I'll share that with you at the end of this short talk. Okay, the first heart sound to me is the most informative heart sound in the heart. And Dr. Shea, who's going to speak after me, when he was a fellow, did a project to prove that, and I'll tell you why I feel it's important, and I'll introduce the concept of the first heart sound gradient, which again Bill will expand upon, but that's what we call it, Bill. I don't think we used that term when you were working in the lab. Okay, so this is a classic phono, which is about what you see when you turn on the scope. And so I took this picture because it was pre-labeled and everything else, and you can see the first heart sound is very complex. It tends to be louder at the apex, but it should not fade out too much when you get to the base of the heart. And again, Bill Shea is going to tell you what that means when it does fade out, when the gradient is steep and the sound goes away. But this has many components, and they should be tightly wrapped, and they should begin, as Arvind said, with a low frequency sound that might be really the fourth heart sound. That might be in a normal situation the fourth heart sound. And as you know, the rate of ventricular contraction is what determines the intensity of the first heart sound. And this is incredibly valuable. You're in the emergency room at night. Patient comes in. You put the stethoscope on, and bang, there's a loud first heart sound, or an intense first. I shouldn't use the word loud. That's terrible. Intense is the word. There's an intense first heart sound, and you know that you're going to have a pretty normal ejection fraction. Certainly if the blood pressure is also normal or high. You could really move on to other types of heart failure if there's heart failure or other diagnoses. And so this is so valuable as a first impression. Now, you can get into trouble, of course, as shown here. Here is a Vinkelbach type of AV block, long PR interval, drop beat, short PR interval. And you can see the first heart sound when the valve is already closed before the QRS is almost non-existent. And then when you get to the normal PR interval, the first heart sound is booming. So if you're dealing with a valve that's already closed, you might lose your first heart sound, and it wouldn't give you information about left ventricular function necessarily. So there are some pitfalls to this. Now here's an example of where this really comes in handy. This is someone with a cardiomyopathy. The echo clearly shows it. And here the first heart sound is way less intense than the second heart sound. And for those who like third sounds, there's even one of those. But what I really like about this is not only is it less intense, but in the face of a wide QRS, you can see that it's might be split. The components are separated. And that may be an early sign for resynchronization. That may be something you can follow or send you down the road to thinking in terms of resynchronization if the patient has a wide QRS to start with. So we not only, and it really helps to see this while you're listening to the heart. You may not believe your ears, so to speak, until you see it. The second heart sound, fascinating. Look how tightly related that is to valve closure. Here's an M mode showing the exact moment of closure of the aortic valve, and there's your second sound generated at that precise moment. I love this, this picture. We used this in Cath conference once years ago. And as Arvind taught you already, you get a wide split sound in a right bundle, A2 greater than P2 and A2 before P2. And in the left bundle, when the patient breathes in, the split becomes shorter, narrower, because there's a reverse split, paradoxical split, due to the delay in left ventricular contraction from the left bundle. And so you can visualize that very readily. Pulmonary hypertension, P2 is greater than A2. Another thing you can visualize. When it comes to murmurs, really cardiologists are constantly getting patients sent to them when an internist hears a murmur and says, oh, refer to cardiology immediately. And that takes up a lot of time in my clinic. I don't know about yours. And definitely innocent murmurs are very clearly identified from aortic stenosis, HCM, mitral regurg, and pulmonary stenosis. This diagram doesn't really do it justice. It should be even earlier than shown here. And I'll show you a real innocent murmur. Here is an early systolic murmur right after, the same picture I just showed you, a little brighter. And the murmur is all over by the middle of systole. And look at this, it matches the vibrations on the aortic valve almost at the same frequency. And they used to teach us it was the pulmonary valve, but I see this over and over again, and I think the innocent murmur comes from the aorta, not the pulmonary. So here is an example, and we could see this all the time when we are doing dynamic auscultation and really identify the innocent murmur quite easily. The pathologic murmur, of course, I hope Mike Wren is here, maybe not, yes, oh, good. He's going to talk about our work with echo and the second transient heart sound, but we can also see this very clearly with the dynamic auscultation. And of course, this is a more pathologic murmur with more duration, more intensity. And then here, the second sound is faded down to almost nothing, and this has become later. And these things can be identified, as Arvind said, and will be future research for us. We're going to do research in this area for sure in the next year and try to develop some algorithms so that once you identify AS on echo, you can maybe cut down the frequency of recurring echoes. Our own lab has become so overwhelmed that in the last few months we started doing up to 70 echoes a day, and we just can't keep up with them. And some of them are, echoes every 3 months for people with AS who don't need it. So I really commend that to your attention. In hypertrophic cardiomyopathy, also the murmur, which is late typically, certainly tells you where the obstruction is, when it's occurring. Here's the aortic valve open, and then it shuts here. Dicrotic Bispherian pulse at the same moment. Murmur peaks at the same moment. But now you know that sequence of events. You can visualize it in real time with dynamic auscultation. And I've used this in a number of my patients who I follow with HCM. Mitral regurgitation. My favorite thing about mitral regurgitation is, of course, we know the more severe levels are pansystolic and the milder ones are late. But here's a prolapse patient, and here's a classic late systolic murmur. Well, I can't tell you how many patients I get sent. Does this patient need cardiac surgery? And the patient is scared to death, and all they have is a late systolic murmur. It's almost always mild when it's late. Once in a great while, it might not be. But I'll tell you something, if you see it like that, you can pretty much reassure the patient on the spot. Maybe you'll do an echo, maybe you won't, but this is a very reassuring finding. Here again, the first sound, you can see, here's the closure of the mitral valve, and you can see that some of the components kind of occur earlier, and particularly this low frequency guy, which is probably the S4 part of the first heart sound, if you will. Maybe I'll get some argument from our panelists. We are going to have a little panel after this, so we'll get a chance to bat that around a little bit. Okay, this is just another late systolic murmur with a click right there. And then here's just a click all by itself. And then finally, something I've had a lot of experience with lately, patients come in with pulmonary stenosis. Now, that's not a common public health problem, particularly among adults, but I'll tell you that the patient might have a middling gradient of about 40 or 50, and yet the symptoms are bitterly complained of. And so if you listen to one of these patients and they have an intense murmur like this, I tend to tilt toward thinking that the gradient is high and that the patient has a severe lesion. And those are the patients where I worry if they get pregnant, and I certainly would have a low threshold for balloon angioplasty when there's an intense murmur like this, rather than just an early simple murmur. And I've fixed a couple people who had borderline gradients on echo, and they've all had dramatic improvement in their symptoms. So again, the auscultation, the dynamic auscultation, extremely helpful in that case. Mitral stenosis is sort of a curiosity in the United States. When I started out, that's all we talked about. Mitral stenosis every day. This is left over. What's interesting is the patients I used to see with mitral stenosis were people that were kind of born in the 20s and 30s, and they're not around anymore, yet there are lots of people born in the 20s and 30s around. So I'm thinking it wasn't too good for them. I have stopped seeing it, and yet there's still people from that cohort. So it's just sort of an epidemiologic aside. And of course there are diastolic murmurs associated, and my favorite, the opening snap, and you can time that interval for severity, and in some countries that'll still be very important. Now, blood pressure. A trick that I learned from Dr. Jules Constant, who wrote a very wonderful book called Bedside Cardiology, is to, when you're taking blood pressure, is not to have the shirt on, certainly, and to listen to it yourself rather than use an automated cuff. And what you do is you ask the patient to open and close their hand about 20 times, and then you listen to the blood pressure. If you use the lung filter on the dynamic auscultation instrument, if you do that, you will hear the sharpest, most demarcated blood pressure. It is so precise to know exactly the moment when when the blood pressure is reached. Sometimes it's not so obvious. Sometimes the sounds are distant. These are banging and crisp. And this way, I do orthostatic now in almost any patient, and I take the blood pressure myself. Half the time I come in, the fellow hasn't done it, and I do it. And we've come up with a lot of people that are orthostatic, and we feel like it's a very precise measurement. So I want to recommend that is a very helpful part of this instrument, is improving your blood pressure. Not yours, but the patient's. Okay. And then breath sounds, excellent. I won't go into that too much, but the precision of the breath sounds is very good. And so finally, there's some limitations. Patients get scared. You come in there and you kind of jump into the screen, and there you are staring at the first heart sound, inching your way up, wondering whether the EF is going to be normal, looking at the splits. There's so much to look at. And so it does expand the time. It does take up time, and the patients get frightened. What's the matter, doctor? Nobody ever spent that much time looking at my heart. I know there's something wrong. You're not telling me. I've had that conversation a few times. And they always try to look at the screen, but generally they really like it because you're a specialist now. You're really spending time doing what they really kind of expected you to do. Now I find myself disrobing everyone. Our technicians that bring the patients in, they've gotten the habit of just leaving all the clothes on the women. They put the ECG leads around. They don't take the shirt off. They don't do anything. And now I've sort of made them do that, and they don't like it, but at least we get to listen better. And so you also have a lot of choices. With choices comes a learning curve, and one has to relearn auscultation. It's a great pleasure, let me tell you, but it has to be done. It doesn't just jump out the first day. So it's an exciting addition. Just yesterday, I don't know if, I can't remember exactly who was with me, we were listening to a patient. I look at the screen, and there is the loudest ejection sound I've ever seen. I had missed it on I would have missed it on a cursory exam. I think the fellow did miss it. And that prompted us to look at the echo, and they had missed a bicuspid aortic valve. This ejection sound was just popped right out. It was so beautiful. It's also kind of, this is analogous to the handheld echo, except that this is useful, it works, and nobody seems to use the handheld echo very often. So I think there's some analogy and there's some non-analogy. So with that idea, we'll learn about some research ideas that were generated. I'm going to ask Bill Shea to come up now and tell us about the first heart sound, what you learned in your research.